Systemic lupus erythematosus or SLE. It is a systemic disease. It is a predominantly adult disease. 80% of the disease load in the adult population, but raised 20% or so in the adolescents or the grown-up children's issue. More common in the female, 9 is to 1, at, at the age of 12 to 18 months, 10 to 18 months also they have incidence. And the disease is quite severe in children. When do they occur in children? As I said earlier, less, but when it does occur, it is quite severe. Renal involvement is found 80 to 60 to 80% of cases, and is quite severe, leading to the high mortality and morbidity compared to its adult counterpart. How to diagnose these things? How do present? These children present with your fever, rash, oral ulcer, alopecia, joint pain, proteinuria, hematuria, convulsion, your renal impairment, and your distress, pleural effusion, pericardial effusion, and skin involvement, discoid, lupus, subacute, chronic, and they have muscle pain, they have CNS symptoms like delirium, psychosis, and seizure. How do diagnose these cases? They are to be diagnosed by anti-DNA positivity, found in 70% of cases or so, but it is quite specific, found in 95% of cases of lupus. And ARA positivity is the first screening test, and then C3, C4, both are low, and blood count helps to some extent. And renal involvement is diagnosed by renal biopsy, routine microscopy, and creatinine and protein in the urine, and the C3, C4 low. And how do you treat? The treatment is milder cases in the stage 1 and 2 lupus nephritis are treated with the oral prednisolone and hydroxychloroquine, and photosensitivity sunscreen. Hydroxychloroquine is a drug which prevents the flare, disease progression, and protective to different organs of the body. And the prednisolone and then hydroxychloroquine are the first choice for the stage 1 and 2 disease. 3, 4, 5, mostly 3, 4, they are the proliferative lupus nephritis. They are to be treated with the IV methylprednisolone. Cyclophosphamide, maybe IV, maybe orally. IV one is safe, less toxic, total loss cumulative dose is less. So give the very effective for the lupus nephritis and systemic lupus, other lupus also. And then you have alternative drug, MMF in the a little bit milder cases. In a little bit difficult cases, you have cyclosporine and tacrolimus and voclosporin. And finally, you have monoclonal antibody like rituximab, and currently used monoclonal antibody is belimumab. And then finally, your respiratory refractory disease, you have plasmapheresis, and newer therapeutic or your newer modalities of treatment, and the antihypertensives as it is needed, antiproteinuric RAS inhibitors, the ACE inhibitor, ARB, they are the drug chosen to treat the hypertension and proteinuria in these children. And statins in dyslipidemia, they are quite common. And joint pain is a painkiller, maybe paracetamol, maybe NSAID. And presenting with RPG and IV methylprednisolone. And maintenance drug, bring the patient into remission by 3 to 6 months, and go for maintenance drug with prednisolone low dose and MMF maybe azathioprine also. Go on giving it for 2 to 3 years, not more than 5 years, and most of the time you have happy outcome, you have disease-free state, and continue following the child and wait. If disease flares, you do treat. Even if it doesn't, you go on having lifelong follow-up. It can come at any time. So prognosis is not that good in children, and good amount of patient loss and mortality and good amount of suffering. So morbidity is there. Then at the end of everything, there can be a little bit of smile. Good amount of children, they remain alright. Good amount of adult prognosis is a bit better.